So I'm going to share with you ptosis. As you know, ptosis is drooping of the eyelids, and it is a very common oculoplastic disorder. You'll see it in every clinic. However, the management is really challenging. Not only the surgical, even if you decide for medical management or waiting or discussion with the patient. So despite being common, it is really challenging. The majority of the cases are either congenital or involutional, and other types can be grouped under the unusual types of ptosis. Ptosis can be simple, only affecting the levator without any other extraocular muscle affection or any other syndromes. Can be Marcus-Ganjo-Winking syndrome, blepharophimosis syndrome, or maybe acquired due to medical issue or post-surgical. The usual complaint of the patient is drooping of the eyelid, but sometimes they are coming with abnormal looking eyes, noticed by themselves during selfie or by surrounding, or abnormal eyelid contour. Also, elderly patient might complain of decreased vision due to visual field restriction. So what we should do in the clinic, we have to address patient's complaint. So it is recommended to get a mirror and Q-tips and ask the patient exactly what is complaining of. For instance, this patient, she's complaining of ptosis. However, the actual issue here is the hooding of the skin, but the palpebral fissure height is comparable to the other side. Dermatochalesis here can be bilateral, and patient is also complaining of ptosis. So when we start to evaluate the patient, we have to put some questions in our mind and has to be answered at the end of the evaluation. So first question, what is the etiology of ptosis? The second question, when imaging study is indicated, and when we should refer the patient, which type of surgical procedure is indicated, and when early or even urgent management has to be done. Never ever forget when and do not ask about cosmetic intervention in front of the watcher. Also, you have to clarify previous ptosis or lid retraction surgery. Maybe a patient has like this thyroid or ptosis, and after surgery, they have ptosis compared to the other side. Or if the patient has previous ptosis surgery, because the amount of levator resection is completely different. We are resecting more than 14 if this is a primary intervention, but in secondary intervention, usually we are resecting 5 to 8 millimeters. And it's also important in the discussion because any amount of resection in revision would be aggravating the lack of soundness. Also, if the course is stable, congenital ptosis usually does not improve with time, nor getting worse, or if it is improving or worsening, like medial third nerve palsy or involutional ptosis, which is getting more and more with time. The family history is important for the medical history, anesthesia, and patients with congenital ptosis, they have higher incidence of having congenital heart disorders. So don't forget to ask about congenital heart diseases. If the patient has blepharophimosis, also male or female, because if she's female, she tends to have ovarian failure. So at the end of the history, you should figure out the etiology of ptosis. You should pick up dangerous ptosis, and when imaging is indicated, for instance, if you are suspecting fracture, orbital mass, third nerve palsy, surgical third nerve palsy. And then mostly you decided whether you need to refer the patient or not if he has associated systemic illness like myasthenia gravis, and you filtered already cosmetic-induced ptosis. Now we'll move to examination. When you examine patient with ptosis, especially if a child with ptosis or during infancy, the major question that you have to address, should I operate him now, or I can wait safely till the preschool age? This question would be answered upon covering of the pupil, partial or complete, with the ptotic eyelid. The child is always moving and he starts to cry, so always start with addressing this question. How do we address this question? In colored iris, it's very easy to see the pupil, is it covered or not, because of the contrast between the dark pupil and the lightly colored iris. In our community, the iris is black or dark brown, so very difficult to see this one. So it is recommended to highlight the pupillary area with the ophthalmoscope. So hold the direct ophthalmoscope away from the child, so he won't agitate him and he won't cry, and see if the red reflex is rounded, so clear, the pupil is not covered with the eyelid, or a D-shaped if partially covered, or absent if completely covered. But when you do this, you have to be on the same level of the child, because if you are sitting higher than the child level, he tends to look to you up like this, so he is aggravating the opening of the eyelid, and you have overestimation. And if you are lower than his level, he tends to do like this, so he's overestimated the issue, and the eyelid is actually, the ball is actually going down, so you will be having the sensation of, no, it is not covered, while the actual situation is partially covering or total covering of the eyelid. So it's very important to sit on the same level of the child. After that, look at the lid crease. If the lid crease is obvious, it means that the levator function is not good. So you may handle the levator. But if the lid crease is faint or absent, the levator function is poor. This is, by the way, all these with inspection. You don't approach the patient yet, because once you approach the patient and if he starts to cry, you won't be able to get any further information. The most important data in lid evaluation in cases of ptosis is the vital eyelid signs, in particular the levator function, because it dictates the amount of resection and even the type of surgery that you're going to do. So you have to measure the palpebral fissure height, which is the distance between the upper eyelid and lower eyelid in the primary position of gaze, and then divided into MRD1 and MRD2. MRD1 between the lower, MRD1 between the corneal light reflection and upper eyelid. This is MRD1. And MRD2 between the lower eyelid and the corneal light reflection. It is important to document both, because sometimes the eyelid is retracted in one side. So despite having the same palpebral fissure height, he has true ptosis because of the differences in the MRD1 and the MRD2. They divided it into mild, moderate, and severe. If 1 to 2 millimeters covering, this is a mild, 3 millimeters moderate, 4 millimeters or more severe degree of ptosis. As I told you, the lid crease shape and the height is important. If you have severe ptosis with absent lid crease, meaning that the levator muscle itself is having some fatty infiltration, and mostly the levator function needs more resection and are likely to have improvement postoperatively. If the lid crease is evident, mostly they have fibrous band that you have to release the retinal ligament, and levator function is likely to improve postoperatively. If the lid crease is high with thin eyelid and the levator function is excellent or good, this is a diagnostic for levator dehiscence, either involutional or aponeurotic type of ptosis due to other causes like frequent rubbing or contact lens user, VKC, etc. How to assess the levator function? First, you have to fix his eyebrow, because if the patient is using the eyebrow, he will give you overestimation. So fix his eyebrow with your finger and use a ruler Black ruler is a good one if you want to take a photos because of reflection. And as you can see here, the eyebrow is fixed in both photos at 30. So he is not using the frontalis. Ask the patient to look on the extreme down gaze and then fix the ruler here, for example, here in 13, and ask the patient to look at the extreme up gaze. As you can see here, it's almost 23. So the excursion or the journey taken by the upper eyelid from the extreme down gaze to the extreme up gaze is the Levator function. And this is 10 millimeters here. If the Levator function is 4 millimeter or less, we consider it poor. If 5 to 7, we consider it fair. If 8 to 12, we consider it good. And more than or equal to 13 is excellent Levator function. You might find some little difference in these numbers, but this is in the Frank Nisi oculoplastic reconstructive surgery, which is adopted by most of the clinicians. As I told you, always remember to fix the eyebrow, and here also from the extreme down gaze around 26, extreme up gaze around 30 or 29, so 3 to 4 millimeters here, the Levator function. The lid lag, we have two types of lid lag. The static lid lag, when the patient is looking down, and at this position, we will see the eyelid. This is a ptotic eyelid. You would expect that this is lower than this one in a primary position. So if he's looking down, this one will be lower also. But in congenital ptosis, no. The ptotic eyelid, because the relaxation of the muscle or the fibrosis, which is happening at the level of the levator aponeurosis, is restricting or preventing full relaxation of the eyelid. So the eyelid is higher. You can see it here. The area of sclera is evident. And this is what we call it lid lag. This is the static type. The dynamic type, you assess it while the patient is moving from the up gaze to down gaze. And this is characteristic for thyroid orbitopathy, the dynamic one. Then, when should we operate? If the patient has mild ptosis, like this one, or even moderate ptosis, partially covering the pupil, the decision of surgery is depending upon the psychological condition of the patient and family. Always remember, when you do it under local anesthesia, the satisfaction or success rate is higher because you can adjust it while the patient is sitting, unlike if the patient is receiving general anesthesia with muscle relaxation. So you are depending on the measurement preoperatively and on the position of the eyelid intraoperatively. So we are, generally speaking, 1 in 10 we may redo in local anesthesia, and 1 in 3 will be in need for another surgery in general anesthesia. So usually we treat the patient at the preschool age because the classmates start to tease the child. So if the parents are coming and noticing that the patient is looking at the mirror frequently, he's asking why I don't look like others, why they are telling me like this, like that. So it is indicated to treat for the psychological condition. And putting in mind under general anesthesia, so we might redo. This is why we are correcting them at the 4.5 years. So by the time that he's admitted to the school, if you need to go for resurgery, you'll have plenty of time to do that. But we have exceptions. If the patient has severe unilateral ptosis, this means that the patient is likely to have amblyopia in this eye. So this is an indication for earlier treatment. Or if the patient has bilateral severe ptosis, because he will adopt chin up position and will induce deformity of the cervical spine. It is not urgent, so we don't treat patient with ptosis as early as the first few months, because while the patient is lying flat, so he will be able to see even part-time by this eye, which is covered partially or complete. But when the patient starts to sit, and this is usually at the age of 9 months or 9 months or 1 year. and he's interested now in surround. So he will start to adapt to the head position, or the eyelid will be most of the time covered with the ptotic eyelid. So usually we treat them at the age of 1 year. After you finish the examination with the eyelid, vital sign, don't forget the following. First, don't forget to move the jaw, and take the mother complaint cautiously. If the mother is reporting that the eyelid is moving while the patient is eating or chewing or sucking, even if you could not detect it in your evaluation, no, take it seriously, and he has Marcus Ganjo winking phenomena. And it's not essentially while the patient is opening the mouth. It might be with moving the mouth anteriorly or sideways, as you can see it here. It is important to detect this subgroup because treatment is different. If the patient has evident ptosis, you have to disinsert the levator completely, attach it to the ostium, and then do frontal sling. So no rule of levator resection in these patients, even if they have mild to moderate degree of ptosis. Extraocular motility is also important because third nerve palsy is a possibility which may be fatal if you missed surgical third nerve palsy. And when you decide to treat, if the patient is partially recovered and he's keen to have ptosis correction, you have to test first for diplopia. So elevate the eyelid and ask the patient if he sees double. If he has double vision, this is a protective ptosis. So ptosis is now preventing him from the severe headache that he may have it if you correct the ptotic eyelid. So first, be sure that the patient has no diplopia when you correct ptosis by elevating the eyelid. If he has, send him to the strabismus neurologist to correct this deviation of the eye, and then go for ptosis correction. Extraocular motility, you may have third nerve synkinesis. So also in this situation, you have to be sure about the treatment option. If the patient is having remarkable ptosis, you have to go for, like Marcus Ganjo winking, disinsertion of the levator rather than correcting the ptosis, and we will have very unsightly lid retraction while moving the eye globe. Also, if you have complete restriction of the extraocular motility, like chronic progressive external ophthalmoplegia, any amount of correction, the eye will be exposed, exposure lag ophthalmos, and the corneal complication is likely to happen. So usually we don't treat these patients unless if they are really bothered with this one or adopting a head up, chin up position. And if you operate such a patient, you have to operate with something that you can take it back. So the best option here is to use a silicone rod or Dyna rod. So after surgery, you can readjust it with local anesthesia, just open over the sleeve here, and you can relax or tighten the sling accordingly. Bell's phenomena assessment is really, really important. As you can see here, this patient has moderate to severe ptosis. And when we assess the Bell's phenomena, by just ask the patient to lightly close, don't ask him for forcible closure, lightly close the eyelid while you are opening the eye, so the eyeball will going up. If he has any defective Bell's phenomena, any exposure is likely to have any lag of ophthalmos, postoperatively is likely to have exposure keratopathy. And as you can see, this patient has complete lack of Bell's phenomena, and he had been treated elsewhere and complicated with keratitis and dysmatocele here. If you have mild ptosis, don't forget to look at the pupil because Horner syndrome has to be ruled out. As you can see, the pupil here is smaller than this side. And Horner syndrome may be fatal, by the way, because if we have any heavy smoker, apical carcinoma, or dissecting aneurysm of the aorta in the neck region, so you have to be very energetic. You have to refer the patient for neurologist, for imaging, for MRI, before considering myeleurectomy, which is the best option in treating such a patient. Don't forget hearing loss for the issue of reciprocal innervation. This patient has left ptosis. When we elevated the left ptotic eyelid, the other eyelid drool. So this is not the normal for this patient. This is the normal. So post-operatively, once you corrected the ptotically left upper eyelid, patient will complaining of induced drooping of the other side. So he's telling you, what have you done with the other eyelid? So you have to pick up those patients ahead of time. And this is also important for the level of correction. So you will correct up to this level or this level. So it has to be, you have to have thorough discussion with the patient and tell him that we'll correct it to a normal position, and mostly you're gonna need for another surgery on the other side. And you can see here in this video, how does it look like? You can see he has the right ptosis. When we elevated the right eyelid, the left one is going down, you see? Okay. So you have to be sure about these patients and to have a discussion about the post-operative outcome. Of course, in pediatric age group, you have to assess the visual acuity and possibility of amblyopia, and post-operatively, you have to be energetic in managing those patients. Also, ocular examination is mandatory, not only for the evaluation of the cornea and the dryness, which will be aggravated by the widening of the palpebral fissure height, but you may have a clue of the cause of ptosis, like this patient who has dilated tortuous blood vessels here, and he proved to have the carotid cavernous fistula. Also, you may have the Al-Faky or the pink colored conjunctiva, which represent the continuous rubbing of the eyelid as an etiology of apneurotic ptosis. Counseling patient for ptosis surgery, always remember, 1 minute counseling will save you 1 day fighting with the patient post-operatively. So you have to take time with the patient. And if the patient has a informed consent, so he knows what's going on post-operatively, first, the trustability between the patient and you will be really very high, because you know what will happen post-operatively. So if the patient has lag of thymus post-operatively or lid lag, which is actually not a complication, they are a side effect of ptosis surgery rather than complication. If you tell him ahead of time, this is going to happen post-operatively, so once he has it, it's not strange for him and he knows. So on the other hand, it will increase the trustability between you and the patient, and they will be prepared for such an instance. The counseling the patient, including also the need for lubrication and the lag of thymus or lid lag, need for another surgery if you need it. If you tell the patient about these possibilities ahead of time, post-operatively will not only be ready for this, but also will be keen on compliance with your treatment. So the most important, as I told you, is the lid lag and lag of thymus, which is actually not a complication. It is inherited in the way of treatment, because you're going to resect part of the muscle, so ambulatory relaxation won't happen. Or if you fix it to the eyebrow, so utilizing the frontalis, trying to open the eyelid, is likely to happen. The major question here, the patient will ask, okay, it will be forever or it will be improving. It depends upon the amount of the levator function. If the levator function is reasonable, it tends to improve because the amount of resection will be less, but never ever give promises, because we've seen patients when the levator function is good and we expected that we will not have that marked lag of thymus, but it tends to have lag of thymus because there is some sort of equilibrium between the orbicularis muscle and levator, protractor, and retractors of the upper eyelid. So tell them that it will happen, it's going to improve with time. Mostly, if the levator function is good, it will be very insignificant, but we cannot promise it might be significant. After how long? It takes months or years to improve. So don't be agitated with these issues. If they are not compliant or the Bell's phenomena is not intact, they may have developed exposure keratitis and at this situation, you might go back and induce ptosis again if they are not improving with lubrication. So after examination, you picked up dangerous ptosis and you decided when you should refer the patient if you missed it from the history. You've chosen already which surgical procedure is indicated for this patient and when early or even urgent management is indicated. And also when surgical management should be avoided or delayed, as we mentioned before, like in patients with third nerve palsy. We'll have some few notes about the most common types of ptosis, simple congenital ptosis and the aponeurotic ptosis. So in simple congenital ptosis, we are not talking about congenital ptosis associated with peripheral phimosis, chronic progressive external ophthalmoplegia, Marcus Ganjo winking, or other kinesis or weakness of the elevators. So the simple type is dated since birth, range from mild to severe, so it's not essentially to be severe, with stable degree of ptosis. It's not improving with time nor increasing in the severity. The patient has static lid lag, not dynamic, and the simple type, they have full extraocular motility with good Bell's phenomena. The simple congenital ptosis might not be evident, and with time, if the patient develops involutional type or aponeurotic type, it becomes evident. So it is very important, even if you see patient with aponeurotic type, but the patient still has static lid lag, to look at an old photo before or prior to the starting the condition, or the patient noticed his drooped eyelid. It can be mild, moderate, or severe, and this is the lid lag, as we mentioned. As I told you, and I'm always telling the resident, congenital ptosis, you always mentioned that the lid crease is absent. No, the lid crease is related to the amount of levator function. Congenital ptosis might be mild, moderate, severe. The levator function might be excellent, good, poor, fair, depends on the degree of ptosis. And the lid crease might be evident, might not be evident. So absent lid crease is not a feature of congenital ptosis that you have to see it, even in the severe form. Clear this point? The treatment of simple congenital ptosis, it is at the preschool age, because at this age we have accurate preoperative examination and reliable measurement. And if you have surgery based on inaccurate measurement, is bound to fail. Usually we resect 1 to 6 or 1 to 8, whatever. But what am I doing in surgery? If the patient has levator function, mild ptosis with excellent levator function, resection will be enough for 16 millimeters. And if he has moderate ptosis, usually 18 to 20, severe ptosis above 20. But during surgery, you have to look at the position of the eyelid. If the levator function is 7 millimeters, this is the cut line. Above 8 millimeters, go for slight undercorrection. So when you look at the position of the eyelid intraoperatively, put it slightly undercorrected, because it tends to go up after surgery. If the levator function is less than 7, go for overcorrection. It tends to have some drooping postoperatively. If the levator function is 7, put it exactly where you like to put it. So mild ptosis, the resection is around 16 millimeters. If excellent levator function, if good or fair, 18 plus minus 3. And always think that you have plus minus 3 according to the position of the eyelid. In congenital ptosis, look exactly at the contour of the eyelid. You might have excellent correction, but the unequal pretarsal show or notching of the eyelid, drooping of the medial lateral aspect will make the patient unsatisfied. So be careful about reformation of the lid crease on exactly the same position of the other eyelid. Make slight overcorrection on the lateral aspect because this is the one which tends to droop postoperatively. Don't tighten the medial one. This is most likely to have notch. So these are the tips during surgical correction to avoid unsatisfactory results. In some patients, as we mentioned before, you have to treat them at earlier age group. If the patient has unilateral severe ptosis, the pupil is partially or completely covered with the pupil, with the eyelid, to avoid amblyopia in unilateral cases, or in bilateral cases if the patient has chin up position to avoid cervical deformity. And usually we treat them between the age of 6 months to 1 year. Always remember amblyopia, and you have to treat it post-operatively. This is the exception, lateral severe ptosis and bilateral adopting head posture. The Levator resection can be done through anterior approach or posterior approach. Usually we do it through anterior approach for better visualization, good exposure, better localization of any fibrous sheet, fibrous band, releasing Whitnell ligament. And the anterior approach is more predictable, at least in my hand, than the posterior approach. The posterior approach reserved for patients who is overcorrection is likely, because if we have posterior approach with overcorrection, easily to vertebral the eyelid and release the suture post-operatively, and the patient will have better results in posterior approach. So we'll start with skin incision and then tend to the orbicularis muscle up and cut the orbicularis to avoid damaging of the levator, and then open the orbital septum. It is multi-layered, and don't open it close to the tarsus because we have only here 4 to 5 millimeters. So if you open it very lower here at the lower end, you may damage the levator. So make it in the middle. And once you open it, brace on the globe, you will find the friendly fat, pre-aponeurotic fat. Any structure under the fat is the aponeurosis. Retract the tissue here, retract the fat, and then dissect the, this is the orbital septum open, and this is the muscle. Then dissect the orbicularis here from the tarsus. And once you expose the tarsus here, shave off the levator. And you can have the levator here dissected from the mular muscle, or take it with the mular muscle together. And if you have mild ptosis, no need to cut the holes. If you need to resect more from the levator, you need to cut the hole. And this is the levator muscle here. This is the anatomy muscle, and the orbicularis retracted with the skin, pre-aponeurotic fat, levator. If you have vasculature here, this is the mular muscle, and this is arcade here. And then fixes the tarsus to the levator at the desirable distance with slippery knot, and look at the contour of the eyelid. As you can see, better to look at the contour of the eyelid from the side to avoid the drooping of the lateral aspect, and adjust it according to the levator function. As I told you, then don't forget, after you apply the permanent knots, if you are satisfied with the lid position, to reformate the lid crease. Never ever close the septum, leave the septum to close physiologically, because if you attach the septum to the tarsus, you will have severe lagophthalmos and the eyelid will be fixed in position. So leave it to close with physiological manner. Just to close the orbicularis with the levator fringe to the tarsus, to reform the lid crease, and then close the skin with whatever technique you prefer. If we have severe ptosis with poor levator function, 4 millimeter or less, traditionally we are doing frontalis proud suspension, or if you have Marcus-Ganjo-Winking syndrome. You may adopt many techniques, the pentagonal, the Crawford technique, or you can go for double triangle technique. Open the lid crease and fix it to the tarsus, or do it with a closed technique. You can use materials, the patient's own fascia lata, preserved fascia lata. You can use the silicone rod, dyno rod. You can use Merslin. You can use Prolene. A lot lot of materials actually proposed, but you should have some principles in your mind. First, tell the patients that probably they're going to need for another surgery if you do it early in childhood, and especially if we are using synthetic material. And this is what we are usually used before the age of 5, because we cannot harvest the patient's own fasciolata. So frontalis sling, patients will be in need for another surgery. Second, lag of thymus and lid lag will be evident. Third, choose the material according to the result. Fasciolata is stable. So if you use fasciolata, because the tissue tends to have fibrosis around the fasciolata, and the results cannot be taken back. So if you think that you probably need to loosen the sling or to readjust the sling, use something that you can adjust. And the best, of course, is the Dymarod, because it has sleeve like what we use in retinal buckle. So you can adjust it post-operatively. And this is really crucial in patients with higher incidence of lag of thymus, like third nerve palsy or chronic progressive external ophthalmoplegia. The overcorrection is unlikely with those patients, so try to tighten as much as you can. It is important to adjust the level of the eyelid to have good contour before tightening the frontalis sling. And position of the sling in relation to the root of the eyelashes is also crucial, because if you go up, you may have ectropion or flipping of the eyelid. If you go extreme downward, you will have entropion. So position or malposition of the eyelid margin is also important to be adjusted during surgery. If you have open technique, you can fix it with non-absorbable suture on the tarsus, so the results will be more stable. This is the same patient with severe unilateral ptosis after being corrected here. If you have overcorrection post-operatively in the first day, you'd be happy, because it tends to have drooped a little post-operatively with a couple of days. These are the complications that we mentioned regarding lag of thymus, and she has also lash ptosis here because the application was too near to the root of the eyelashes with shortening of the posterior lamella. So be careful about the positioning of the sling in the eyelid over the tarsus. The aponeurotic type, on the other hand, the characteristic, the eyelid, the crease would be high or absent. The levator function is excellent or good. The eyelid tissue is thin because one of the layer, what we call it middle lamella, is recessed up. And on the other hand, we mentioned that in congenital ptosis, the eyelid will be having lid lag, static lid lag. Here, no. The eyelid will be drooped more in down gaze. As you can see here, patient has bilateral, more on the right side with high lid crease here, but the levator function is excellent. And this is the aponeurotic type. Involutional type, they assume that there is a microinfarction of the levator aponeurosis. This is why it become higher. And in some patients, post-operatively, even with lid speculum, as I told you, it might happen, or the lid, the attachment was not that strong with any manipulation of the eyelid. Even in refractive surgery, the patient may have drooped of the eyelid. And in these situations, acquired type, take measurement, wait for 6 months, be sure that it is not improving, and you have to treat only the residual. The aponeurotic ptosis is one of the simple procedure. You don't need to open the full lid crease incision. Small lid incision will do the job. And usually the patient is satisfied because we don't resect, so lag of thymus and lid lag is unlikely to happen. So in summary, when you see a ptosis, first you have to exclude pseudoptosis. Be careful about the onset. If the patient has acute or subacute onset in any age group, they are often dangerous and imaging is mandatory. Congenital ptosis are not always simple. so sometimes associated with other features. And myasthenia gravis, jaw winking are frequently missed if you don't ask about them during history evaluation. Look at the pupil in mild ptosis because it may be fatal if you miss the Horner syndrome. Never ever miss extraocular mortality, Bell's phenomena assessment, and hearing is low. Also, recent buttocks injection should be routinely clarified in any recent developed ptosis in adults. And thank you for listening. If you have any question.